story of my life. It took me a minute to log in.
Well, that's
So
why
I
we
heard
do
you
it.
guys talking about the Jags, huh?
Yeah. So
Yeah.
Yeah,
it's not
Gianni,
that I'm
do you follow the Jags quite a bit,
Yes, I
or
do. And they
yeah, you got
disappoint me every single week.
always,
So this
always.
week I didn't even want to watch it. And then I started watching it. I was like, I'm not going to watch it. But I did.
hey, at least we're not the Browns.
Oh, are they bad?
Because the Browns have the quarterback that's $250,000 guaranteed, and he's now injured. So,
Yeah, that's
Well,
and
terrible.
he's been playing like crap. So fun stuff. He's still
I'm
gonna
a
get paid.
FSU fan, so I'm actually happy Jameis Winston gets the start. I
God,
know he's
stop
hurt,
it.
but yeah, they're hey,
Stop it.
at least we can say the Jags aren't as bad as the Browns. There you go. Even though the Browns did beat us in the regular season, but we got a
Yes.
better record.
Yeah, I guess,
But,
right?
Yeah.
I
You
mean,
gotta take it for what
anyway,
it is, Gianni. I mean, it's right now we're on the up and up.
Right now,
on
right?
the up and up, did you?
You take it one game at a time. You take it one game at a time. We're on the up and up.
Okay, all
We gotta
right.
win this weekend.
I'm not gonna burst your bubble.
Be quiet. You got your Rams are the same record as us, okay? And
I know.
you barely got by beating the what is it, the Las Vegas Raiders.
Yeah, I didn't have my starting two wide receivers or my starting tight end.
Okay, well the Raiders didn't have their starting quarterback.
They had great value. They had great value. Trevor Lawrence. What are you talking about?
I don't know. Minshew had a terrible game from what I read.
He
That's
did.
good for
He
you
didn't have a
guys.
great
Good
game.
for you
That's what I
guys.
mean. But yeah, so let's jump into it though. So Ray, you want to do an intro for everybody,
Yeah.
and we can have Gianni give us a little
I was
background
gonna
and
say
kind of jump into it.
I guess we'll start a little early. I mean, we did open
Yeah,
it. I did open this one a little earlier than usual just to make sure nobody had technical difficulties, but it looks like
that's all right.
nobody.
Everybody will jump in when they jump in, and we can kind
All
of.
right, well, we'll get started. So, hello everyone, and welcome to today's webinar. And today's topic of discussion is going to be the critical role of credentialing and compliance in healthcare. I'm Raymond Walters, alongside my co-host here, Jose Delgado Jr., who has
everybody.
17 years of experience in healthcare consulting. Currently owns a mental telehealth practice here in St. Augustine, Florida. And it's also my pleasure to introduce our featured guest today, Ms. Gianni Gonzalez, who is the founder and CEO of Healthcare Management Solutions. And Gianni, glad to have you on here. And just a little bit of background, but I'm going to have you tell the audience a little bit about yourself. But Gianni does have over 20 years of experience in health information, reimbursement management, and she is an expert in credentialing and compliance. And Gianni, again, glad to have you on this topic today, and give the audience a little bit of more background of yourself, if you could, and your
Sure.
experience.
Sure. Thank you, Ray. Thank you for the introduction. I'm Gianni Gonzalez, and I have been in practice here for over, I guess, 20 years this past year. And as you know, my passion has always been compliance. So I basically am involved in all types of compliance as medical records auditing, revenue cycle enhancements. And lately, I started to dabble into the credentialing process, which is another piece where I find there's a lack of compliance, and there are practices that are out there struggling with the credentialing piece where it comes to payer enrollment, right? Because we have credentialing for the hospital sides, and we also have the credentialing for the payer sides. So the payer side has always been a big hassle, and a lot of practice struggle with it. So I decided about a year or so ago, when I was looking into contract negotiations for practices when it came to payer enrollment, I decided that really the credentialing process was a big piece of where we can concentrate on as far as compliance, and as well as streamlining the process for the practices out here that are struggling with it.
So this is one that we can dive into quite a bit. And if anybody's been around the last 6 to 8 months, I've mentioned a little bit about, the struggles that even I've been in the healthcare industry for God, almost 20 years, and it seems as though the insurances have stopped hiding the fact that they don't want to add more providers to their networks. Like it's like they make it impossibly hard, and I'm not quite sure why, other than they just don't want to do the paperwork. Right? Like, I mean,
I think the industry has changed quite a bit. I think after COVID, things changed drastically in the payer world. Before, we used to have these provider representatives that would come into our office that we can talk to, that we can
yep.
go through the process of what's happening with our contracts, where we stand.
If there's an
Now they're
issue, they
not.
would help us out. They would guide us to the right person.
Right. And now they're none. They're non-existent.
Yeah.
Mhm.
It doesn't exist now for some reason. It's wild to me that the insurances have decided that that aspect of the business was not beneficial for them. Because I mean, we were adding providers, we were subtracting providers, but then we had ancient contracts in the insurance world. I mean, the contracts that we had dated back to 08.
Right.
And then they were like, oh, well, because you added so many providers and our original provider wasn't there, then they were like, oh, well, we got to get you all new contracts. I'm like, I don't want all new contracts. I want you to pay me. I don't want to be negotiating this stuff. So it's been interesting to see all of that whole process, and hated it every second of it. Absolutely, like, I'm gonna be honest with you, every second of it I was just like, God, why are we doing this
Well,
again?
I think, like, when we're looking at the process of credentialing, right? It's the processes that you have in place, right? How often you follow up, right? And how much you stay on top of these payers, because most of the time they're not going to tell you. I worked with a practice about a couple of years ago, and I was trying to get her credential with Aetna, and Aetna took a year to get her credentialed. And then when I got an effective date of like 3 months prior to when they sent us the letter, so she lost like 3 months worth of revenue that she could have collected had we received, the effective date at
Yeah,
the appropriate
yeah.
time. Yeah.
Oh, it's absolutely wild. Tracy, I saw that you raised your hand, so go ahead, and if you're got a question, throw it in there. We'll jump into them as we go. It's just been maddening, right? Because you have the game of, okay, I got to get this claim in clean in under 90 days, but they won't go and address our paperwork for 6 to 9 months just to tell us, hey, the panel's closed. And every time we go, it's interesting to me, right? So you deal with this on a regular basis now. We talked a little bit yesterday. I know that one of the things that I am absolutely awful at, and I'm sure that most administrators are awful at it, because the second I say these words, they're gonna be like, ugh. Keeping up with PACOs and CAQH
Right.
passwords and logins,
Right.
and not having that. And then, like, what are some things that you can, as a practice, should monitor periodically just to make sure that everything matches up? Because any little thing to not pay you, these insurances are going to do. And I've seen it like, oh, well, your practice is set up like this under our contract, but you changed your code in why am I blanking on this right now? Your taxonomy.
On taxonomy. Mhm.
Or you added a taxonomy, so now I'm going to deny the claim. So it's like, what would you recommend?
So the your little acronyms, right? I love them.
Yeah.
CAQH, CAQH.
PACOs.
PACOs. CAQH actually has to be updated every 120 days. So, you have to stay on top of that, right? So, how does the practice do that? Either you do a spreadsheet, or like me, have software that reminds me that every 120 days I have to, or prior to that, right?
Mhm.
So if you're also working with like trying to credential with a new payer, like for example, Aetna, you need to make sure that your CAQH has been updated within the past 30 days, or else you're not going to get into that panel, or else they're going to just deny your application. So regularly updating that. PACOs, I just had a provider that he missed his 5-year revalidation. So revalidations are important, like I'm an outsider, right? I work with providers. The insurance companies are going to go straight to the provider and send them their notices. Are they going to send it to me? Probably not.
No.
I would probably never know that they got a
never do.
revalidation. They may be missing. And so what happens when you miss that revalidation? Your money stops coming in.
Yep.
And then you have Medicare that can say, well, I'm not going to pay you back for those months that you missed. And therefore you're going to miss on 2 to 3 months of worth of services just because you missed that revalidation notification. So it's important to stay on top of that. If you're getting any notices, Medicaid is the same. They have the same 5-year, enrollment process or revalidation process that not miss.
So I'm trying to find a way to make this easy, right? So, because I'm going to be perfectly honest with you, I don't know of many office managers that remember to do the CAQH thing you just mentioned. You know what I mean? Like,
Well, I was going to say, let alone practices and physicians, they're getting tons and tons of emails. They could easily miss a notification like that too. Is it just an email, or do they try to call, or?
No,
or,
I can tell you
send letters in the mail for Medicare revalidations and Medicaid.
See.
Yeah. And so I was talking to a Medicaid practice, because I deal with payers across the United States, so not just in Florida. So I was talking to, I believe it was a Delaware Medicaid person the other day, and they were like, when you do your credentialing process, make sure you put your name on everything in there, because it'll all come to you. Otherwise, it's just going to go straight to that office, and then it's out of your hands. So it's how you fill out those forms and who you put in those forms that's important.
Definitely.
Or in these applications.
Because I've seen it to where, okay, they were notifying us, but they were notifying an old office manager, and that office manager hasn't been there in 4 years. That email is defunct, so
it makes you think, what's the process of changing an email? They probably make it extensive.
Fun. Yeah, it is not fun.
But it's easy. You can go to PECOS and update and just check your information. You can go to PECOS. But so I was just involved in this Medicare seminar or a symposium about a couple of weeks ago, and they talked about a lot of the process of credentialing. And, they were also talking about how there's regulations like you would see in compliance, right? Everything changes on a month-to-month basis. So where we were seeing that, where we always see that in compliance, now we're seeing that with payers. So things are going to change. So they were actually stating that the revalidation process right now is only applicable to the groups and not to the individuals, at least from November till like April of next year. But then April of next year, then they're going to start revalidating all of the providers as well as the groups. So it's going to be
because the problem is, right, and I can see it because this was something that we were dealing with. For example, Blue Cross, even with the settlement that they had to just deal with, the 2.8 billion. I don't know if you heard about that one, about them, the antitrust and monopolizing case that happened out in Texas, but it's Blue Cross nationwide. So I see it all the time where they'll go and say, hey, we don't credential mid-levels. So it's only the MDs that we count. So technically it's one provider, but technically it's a group because that one provider supervises 2 mid-levels. You know what I mean? So then it's, how do I do this? How do I bill for this? Not get into trouble because now I got to use, you know what I mean? Like, it just becomes a giant mess because you have billing and office management arguing over the compliance rules, because you're going to have to go and bill under the MD or DO insurance number because they don't credential the mid-level.
No, so it depends on the payer, right? Because all the ones that I've been dealing with, like in Texas, I deal with Blue Cross Blue Shield Texas, but right now I'm dealing with physical therapists, so there might be a different type of animal, but you still have to credential those people, but they might give you the wrong information. Like I received a notice from, I think it's Blue Cross Blue Shield of California, letting me know that the group was enrolled, therefore the other physical therapist didn't need to be enrolled. And I don't believe anybody anyway. So I usually call, I pick up the phone and I make sure I call and find out from the representative, is that true? I got this email and they were going, no, everybody, the group is enrolled, but everybody else still needs to be enrolled, even though the group is enrolled. So those are the kind of things that you still have to follow. And as far as the nurse practitioners, so, I'm dealing with a nurse practitioner right now that has her solo practice.
Yeah.
And she's trying to credential with Blue Cross Blue Shield, and they were giving her the runaround, telling her they don't, the panel is closed. But I think what they were referring to, she wanted to credential as a facility, and yes, panels are closed for facilities, but they're not closed for group practices. And especially your specialty also has a big bearing, right? If you're a primary care physician or a primary care practice, they need a lot of those people. So, and then the collaborative agreement, even though we don't.
Yep, the autonomy. Yep.
Yeah.
Even though she has autonomy, they're going to pay her 75% because she's not an MD or DO. And then depending on the meds she's doing, she needs the collaborative agreement. And depending on the insurance, because again, they don't some of them don't recognize the mid-level. So then you need the MD just to be able to bill. Yeah, it becomes a whole mess.
Right.
So if someone wanted to contract you, what are some of the easy things that they should check so that way they can really maximize how they use your services and your expertise, right? Because we've known each other for some time, but I don't like paying for consultants for stuff that I could have done, but I just didn't know how to do, and it takes 5 minutes, right? Because I want to use you for the stuff that takes 4 hours, that you're arguing with the insurance company and you're going up to management and you have the names and the numbers and the internal rules to get where we need to go. You know what I mean? Like, I don't want you wasting your time with, let's remember our password was CAQH, like something simple like that.
Right. So we keep track of everything because I have a software that we house everything that we need for credentialing. So important things, right? Your CAQH number, right? I mean, I can create a CAQH profile, but more than likely, if you've been in the healthcare business for a long time, you already have one. So we maintain it. We stay on top of adding new information in there, practice locations and updating your liability insurance, which has to be uploaded every month. Your licensures, right? License, make sure that that's updated. If you're like most practices, they forget about that. They forget that you need, and it sits there, right? Unupdated. So, those are the kind of things that I tend to do. So if somebody was to call me and they said they want to work with me, I would probably give them how much it would cost to do enrollments for different things. If you're already enrolled and you just want to offload your payer enrollments to somebody to keep track of it, making sure that your CAQH is updated regularly, that your medical licenses are in there, and you have no issues going forward, then I also do that. I do like a maintenance for that. So.
Gotcha. So you prefer more of the retainer style than the project base?
I do both.
You do both. Okay.
I do both.
Okay.
Like if somebody just wanted to enroll in Medicare or Medicaid, I can do that. But sometimes it's easier, like you said, you don't want to lose that 5 years from now and have a validation that didn't come through.
Right.
So, yeah.
It's one more thing I got to put on the clock and be like, all right, now I got to remember this, and now I got to remember this, and now I got to remember this, and then it's this kind of thing. Really, on that Venn diagram between billing and admin, it's just right there in the middle. So I could see how it could easily be missed by either department, because billing's not dealing with that on a regular basis, because they're only going to look at the credentialing stuff when either they add a provider or subtract a provider. Right. And then admin's never going to look at this stuff anyways, unless they're looking at different opportunities about adding a specialty into the practice or adding certain things so that way they can get paid for it, So I can see how this could easily just fall between the cracks and just have a finger pointing match. So would you say that you work more with the admin side of things, or would you say you work more with the billing side of things?
I'm more the admin.
More the admin?
Yeah, and mainly because they're the ones that are on top of if they're bringing in new providers, right? Like they're on top of that hiring process, and then we want to make sure that they're uploaded. One of the things that I heard, like working through this, right, is that because the whole process can take a long time, right? I have a Blue Cross Blue Shield payer right now that takes 120 days, no less. Don't even ask them before that 120th day, because you're going to get no, it hasn't been processed yet. So what I
Jeez.
heard not too long ago is like some
Oh,
people are giving the advice of, oh, just let somebody else sign it. Well, that can be illegal and it could be a problem, right? So I always say, you know, the practice
Well,
is
depending on how it's
considering
done,
that.
right?
What's
Like
that?
you could, there's ways that you could get around that. It can get very funky very fast, though. You're absolutely right.
Yes. Yeah,
Um,
and the legal aspects of it, right? So I have one practice that was doing that, and I said, you know, contact your attorney, make sure
mhm.
that it's within your contract, like read your contract. If your contract said, if your group contract states that yes, you can bring other people underneath you and you can sign for them, but if you took your brand new contract, no, I don't think you can do that. You know, so
Yeah. Yeah, and then there's I always see now like okay, so first we got to get you and this is and the order is always different with with different insurances, right? Like some of them will be like, "No, let's get everybody credentialed individually and then we do the group." And then other ones are like, "No, no, no, let's do the group first and then the individuals."
right,
And then I have situations where we were literally talking to one insurance company, they were like, "Well, we want you to get credentialed first and then we talk about the contract." And
right.
I'm like,
Yes.
wait, hold on, time out. So you want me to move into this house and then we talk about my mortgage interest rate? Like, how does that make any bloody sense? And I'm just, I'm hoping that maybe you could provide some light with that since you deal with them more than I do. Because that when they told me that one, I literally just I lost it. I lost it. I was just like, you're gonna have to you're gonna have to back up, slow down and explain this to me. How does that work in your mind right now?
No, seriously, it does happen. And it does happen a lot, actually. You get, you know, you enroll and then you get your contract. So, you know, I would recommend seeing a contract first because you may not want to
Mhm.
participate. I have a client right now that has, well, Cigna, you know, Cigna pays
Yep.
usually the lowest payer on earth. And
Yep.
he wanted me to negotiate that rate. And I'm going, it's not going to happen. You're not going to be able to negotiate that rate. So either you say yes or no, you know, you want to take it or not. And he's like, you sure? Just negotiate. And it's not going to happen. It's not going to happen. I mean, if you're a bigger client, which I, you know, I heard your
Yep.
last podcast, if you're bigger and you have a little more leverage, yes, you can.
Yep.
But in the beginning, you know, look at your rates. You know, if they don't include a fee schedule, make sure you get a fee schedule to go by. You know, don't go online and try to figure it out online, like your resources online, because they're not going to
Yep.
be helpful. So get it straight from your payer. Like, hey, you know, I'm looking at you, the possibility. What are your rates? So you can look at it and make an informed decision.
It's wild though, because when you ask that question on the phone, I don't know if you've experienced, but when I was doing this before we got fed up in our practice, and I was just like, you know what, screw it. We're doing Medicare and everything else is cash. You want to argue with your insurance, knock yourself out. Here's a receipt. Bye. Get out of my face. Right. Like it's just not work. It wasn't, it just, I was so fed up. And I know it's not necessarily the most professional way I could put that, but it's the most honest way I could put that. We,
Aggravating.
when we would ask them, hey, look, just let us know what the fee schedule is so we know it's worth it or not for us to invest the time in this credentialing.
Right.
You know, how many patients are you looking at in the area? You know, just basic business questions. And everybody on the phone would be like, what are you talking about? And I'm like, what do you mean? What am I talking? Did I speak Chinese? Like, what do we, what do you mean you don't have a fee schedule for people that you're looking to bring on board? But I have to go through all this paperwork for credentialing.
Right.
Like, how does that not match up? I don't understand.
You know, sometimes I've been able to find, as far as like patient population for certain insurance, I've been very lucky in finding some of that information online. That I could probably say
Yeah.
fine. The fee schedules, yeah, it differs, right? And you might look at
Oh,
you
it's
pull, yeah, you may pull one from another region that has nothing to do with you. So that if you have a representative, you know, if you're lucky enough, if you get a contract from somebody, then I would say reply to that person and say, hey, can you please send me your fee schedule because I don't see it in the contract. I just had that happen with one of my providers. We don't see it in the contract, and he really needs to know. And then we don't want to go fish online because we're going to get the wrong thing, and then we're going to
yep,
advise incorrectly, and then the client is going to get mad at me and say, "What you said, you said."
yep,
So,
yep, yep. Oh yeah.
yeah.
It's
And then
always on us.
and
It's
they
always
do
on
it.
us.
Yeah, they do it. But you're right. The representatives out there are not very knowledgeable, right? Some of them don't even know what you're talking about. and
And
they want to give
I
it to
don't think that they're supposed to know. Like it sounds conspiratorial, right? Like here's my tinfoil, where's my tinfoil hat, Ray? Did you forget to send
Somebody's
me
got to
one?
know. Maybe
You're
not
right.
the.
Like, well, but
nobody knows.
you would be
You got to
absolutely
bump it up the
shocked.
ladder to the
Dude,
top.
right. The lying people that pick up the phone do not know.
Tier
And
5.
those that have been
That's where we need to
around
go.
their supervisors or anything like that, if they do have access to one, I'm not saying that they're not supposed to give it to you, but it is every single time I've gotten one, it has been a very hush hush, here I found something. And you really don't want to bring too much attention to it, right? Like it's been absolutely wild. And then when
It's
you're
kind of
looking at the
scary.
fee schedule, they don't make it easy to read either, right? Like, yeah, you send a list of, all right, and this is what we're looking at. What do you pay for these codes, right, Tracy? And the problem is that depending on your contract, depending on your region, depending on the types of providers you have, they fluctuate so much in my experience. You
Right.
know, Gianni, oh, correct me if I'm wrong, you know, and I sit here and I'm like, okay, let's play the game. You're telling me it's 120% on a 99213 of Medicare, but this Medicare fee schedule you're basing it off of is 3 years old,
Yeah, or
right?
2009.
Yeah. So
Yeah.
you're sitting here and you're like, okay, so then I have to sit here and figure out these are the 15, 20 codes because most offices don't normally use more than 15, 20 codes, especially in that small range. If you're in that medium size range, I could see you doing more than 20 codes, right, Gianni? But usually everything you do is in about 15, 20 codes. And then you just go and sit there. And I know back in the day when Dr. Delgado and I would negotiate, we would always put tangential codes in that list, and we would go and just actively negotiate down those codes and negotiate up the codes that we were using
Right.
just because it was an honest
Exactly.
negotiation.
Yeah.
You know, like it was an honest back and forth with the insurance carriers. Now it's just pound sand. After you spent all the time getting credentialed, you're going to take the contract because you spent so much time doing this.
Exactly.
You
Exactly.
spent so much time.
Yeah, and is it worth it, right? So you have to look at it. I mean, some people are willing to take the cuts right now, and then later on, you can negotiate. Maybe you can send a letter and, like Cigna, for example, they're gonna
Yeah.
pay you $10 and, a visit, and then you can probably next year go and say, hey, maybe I want $15. Can you give me $15? Maybe they will
Yeah.
negotiate at that time. But you're right, depends on the specialty, right? Which are your codes that you're looking to get paid the most of? Like if you're a surgical practice, I think the surgical codes are the ones that are going to be more relevant to how they're paying.
Absolutely.
So look
Absolutely,
at those,
right?
like send them those codes and see if they can give you an allowable on that. And then maybe their E&Ms are not, they're not paying that well, but your surgical procedures are probably worth the contract.
And my personal suggestion, if you're doing procedures in office or in a surgery center, it's check to see if you're getting paid bundled or if it's an actual fee for service, because then that becomes a whole nother bag of tricks too, right? Like you're sitting here like, hey, I've done an ACL, but they went ahead and paid you for the surgery, the pre-op, the post-op, and the rehab all in one go. You're happy as a pig in ish because you're like, hey, I got this fat check. And then you realize, no, I got to stretch this out for the entire life cycle of that client, essentially. So it's wild to me the different things that they do.
Yeah, and like, and then I don't know if you've seen, but when you're looking at visits and minor procedures in an office, you're looking at some of those payers now not wanting to pay that visit and that minor procedure, or if they're going to pay for it, they're going to pay you like 25% or 50%, or so you may need to look at those reductions, and you need to also stay on top of what is changing with those payers when it comes to the reimbursement piece.
The other thing that I found too that was interesting was, again, I'm in Florida, so I see a lot of Florida contracts more than anything else. So when we were looking to get involved with an insurance company, there were certain products that I wanted to be involved with, but there were other ones you couldn't pay me enough to take, but it was almost like they would handcuff me. If I want the good product, they're going to handcuff me to the bad product. And the problem that I found is that every single time I've seen a client of a consulting firm take those contracts, there were more patients from that bad product
Right.
than the good product.
Right. And I
You
know
know,
you're
whether
referring to
it's,
those managed care products, right?
I mean, I'm not trying to put a name on it, but they're the healthcare exchange products normally, right? You know, like
Right.
they're Medicare Advantage without being Medicare Advantage.
Yeah.
You
Yeah.
know, they pay at Medicaid rates, but you want
Right.
access to the PPOs.
Right. You know what the caveat to that would be? Like, do not sign up for Medicaid, right? To me, Medicaid is like one of their lowest payers. And
Mhm,
I used to always like joke around the office and I'm like, you're gonna get $2 for a visit, you know, you're gonna
mhm.
fight for your $2 if you get it.
Yep.
So some of the commercial payers, right, will kind of, you know, if you're signed up with Medicaid, then they're gonna offer you those Medicaid managed care products that are gonna pay similar to that kind of
And
reimbursement.
And it sucks too, because there is a way to make those managed care businesses work, right? Like I don't want to poo-poo that business model, but that business model runs in a completely antithesis format to the PPO fee for service realm.
Right.
And then when you're dealing with now some of these full risk contracts that are coming into play as well. So then it's like, okay, am I going to have to get credentialed now with this ACO that's on a full risk contract too? Or does my current contract with the insurance carrier carry over? Like, you know what I mean? Like, how is this whole mess just creates, do I even want to deal with it? You know what I mean? Like it
Right.
just goes back to the I don't know if I want to deal with it. You know, like I genuinely, and I imagine that most office managers are sitting there. Do I even want to bring this up?
Right.
Is it even worth it?
Right. Well, it depends on your patient population too, right? Because yeah,
Absolutely.
so if you have a lot of patients that have insurance, like Blue Cross Blue Shield, for example, I mean,
Yep.
it's the volume versus
Yep.
reimbursement. So you kind of have to outweigh those, you know, well, you know, I'm going to lose all these patients. So I might have to think about it, the volume
Yeah.
worth it with that. And then also, you know, billing out a network, right? That's also a hassle now, right? Because now we have the no surprise bill that we have to, you know, give to our
Yep.
patients to tell them what, you know, how much, otherwise you're not going to get paid. You know,
Yep.
I just had one provider that was billing out a network and then he got audited. He has to pay back $500,000, and he was audited out of network. Out of network. I mean, we did the review, looked at
Wait. I want to
everything.
dive into this one real
Mhm.
quick. How does you gotta give me more. Like how make that one make sense? I'm out of network. Pound sand. You
Mhm.
know what I mean? Like
Yeah.
I'm taking 60 cents on the dollar as it is because I'm out of network.
But just because you're out of network does not mean you don't have to follow their guidelines. It doesn't mean, and like if they're going to pay you for
Agreed.
their code,
Agreed.
yeah, if they're going to pay you for their codes and they're going to send you money, you still have to follow their guidelines and they can still take their money back. I mean, I mean, I could not save this provider because
Yeah,
they were
yeah.
coming out of network. They were thinking, oh, well, you know, it doesn't matter. We're out of network, but no, it still mattered.
Well,
So,
I mean,
500,000, that's
you're
significant as well.
mhm.
well, I
That
mean,
is,
you're always going to follow the rules for the insurance company because if not, they don't pay you just because you're not following the rules. So I'm trying to figure out how in the world they found a way to not follow the insurance's rule. The insurance paid them, and now they're trying to claw it back. Like I'm trying to. Does that make any sense? Like
So,
you,
yeah.
I'm trying to find an analogy for those that don't quite understand it, and I'm stuck,
So look
right?
at it this
Because
way, Jose. So let's say you're billing out a network, right?
yep.
And let's say you have most of your patients are going to be a level 5 visit because you know you feel that they're really, really sick, and therefore it sets you as an outlier, right?
Oh, well,
So it's
yeah, if
gonna
you're
set,
upcoding like that, you're doing
yes,
something that automatically pings
yes,
you. Yeah, no, of
yes,
course.
yes. It's gonna set you, even though you're out of network and you're thinking I'm safe. No, you're an outlier, and now you're collecting all this money for these patients. And with this one particular provider, I can't remember what kind of specialty it was, but they were bringing the patient in more often than usual. And I think it was a physical therapy. Yeah, I think it was physical therapy clinic. They were
Okay.
bringing providers more than usual. Like, for example, somebody was getting to therapy for like a year. And without
Gotcha.
getting
Okay.
improvement, those kind of things. So if you're set as an outlier, they're going to audit you.
So no, absolutely. On that one, I mean, that one wouldn't have mattered what the insurance company was. They were going to get paid no matter what in that case, right? Because you got to show improvement or you got to show medical necessity
Right.
as to why they've been there for so long. Like I agreed, 100% agreed. But if you're in that, that's why I was sitting here, I was like, they had to have done something.
Yeah,
Like
they did
there
something.
had to have been something that triggered the AI on their end to be like, no, something's going on here. Take a look.
Yeah.
Manually review, right? Like if we
And I
want to
love that
use
you just
this
said AI, because AI is huge now, right? Like
on the insurer
on the
side.
insurance
We
side.
Oh,
can't
yeah.
use it,
Yeah.
but they've been using it for
Yes.
15 years.
And now it's worse
That's how they
because
stay
your
ahead.
denials are like off the chart right now because they're denying everything based on AI.
Absolutely. I mean, what is it? Humana, was it Humana or Cigna just got sued out of California because they were automatically denying so many percentage of claims for, I want to say it was a non-acute rehab. So like post-hospital transitionary, that they got sued for it because of their MA products. But it's a whole bag of tricks. So when I sit here and again, like, I'm a little black pilled on this, Gianni. Like I'm a little bit hurt by these insurance companies right now, So I mean, give me the white bill, get a white pill, give me the optimal, give me why I want to work with them. You know what I mean? Like, because I'm not seeing it.
I know it. To me, it depends on your practice, right? Like
Absolutely.
I'm working with a client that came to me, and what they do is they are autism. They treat patients
Okay.
for autisms, right?
Okay.
This particular lady has her own little is just a different type of specialty. You know where she practices at? The tennis courts. She
I
goes to
believe
the
it.
tennis courts and treats patients at the tennis court. So
I believe it.
if you have a practice like that, right? Would you want to sign up with Medicaid? No.
I don't
No.
see why.
No. Why not? Because they have rules and regulations. They're not going to be happy you're at the tennis court.
Right.
I mean, it would be a logistical nightmare for this
Right.
woman. Like I can only imagine the liability and the fact that they wouldn't pay out because they have for assumptions case, the children outside. You know what I mean? Like
Right.
that's like those horse therapies, the
Exactly.
biofeedback companies,
Yeah. So those I think those kind of practices benefit from a cash only practice, because cash only, you don't have to deal with, any kind of regulations, right? You just bill whatever you want. I mean, like even E&Ms and how you bill for those become obsolete. You don't really need to worry about that. It's a cash base. But
Yeah, but I mean, for me, that's one of those like, hey, even if you have a PPO, you know what I mean? Or you have an HSA, here's the receipt. Go fight it yourself.
yeah,
Go have fun.
right.
Experience what we've been dealing with for the last 20 years, and it's only gotten really bad in the last 15.
I think the only problem that you may come across, like with companies like that, like, so if you are enrolled with a payer, right, then we can't offer cash base for somebody that you're already working with.
Yeah, because you accepted the contract from the insurance company.
Right. Yeah. And then you have to work on their allowables. I mean, you don't have to file their insurance for them if you don't want to, but you have to honor the allowables based on your contract. But then if you decide that you don't want to enroll, but then again, we have the no surprise, and you're going to be doing kind of out of network, and you're going to file the claims for those patients and collect the money. You need to make sure that your no surprise bill or no surprise contract with them, definitely outlines, because you're always going to have that person's going to complain about it, right?
So it's funny that you mentioned that. I was just talking to my staff because they were like, hey, what about this? We should really do this because the patient's going to complain. I'm like, look, there's something you need to understand. This is a bell curve with patients. The ones that are going to complain no matter what you do. And then there are going to be ones that want to complain and never come back.
Right.
But most people are going to be like, hey, if you treat me like a human being, you treat me honestly, I'm going to come back. You know what I mean? Like, just
Right.
because it's the inconvenience of finding a new provider or whatever the case may be, it can be a pain in the butt sometimes, so especially depending on the specialty, so I mean, I'm intrigued. I'm intrigued with where everything goes, like, so if you had a crystal ball and you see all these new business models that are popping up, where do you see this going in the next 3 to 5 years?
So I don't think we can get away from insurances or insurance companies because we have a lot of people that have insurance
Mhm.
contracts or insurances out there. So I think we need to be able to work with them, if we want to continue our practices, depending on what, our specialties, right?
Obviously,
But I
obviously,
know,
yeah.
like as you know, like probably mental health is one of the ones
Hmm.
that decided to want to do mostly cash pay, but it
Yep.
becomes a huge burden on those patients. So patient care, right, is one of some of the things that our doctors struggle with, right? The patient care, making sure that the patients are getting in, but
Yep.
if they don't have the insurance to back it up, it's going to become a problem. And like in the mental health care business, these people have to pay 125, 150, $200 an hour just to see a mental health care provider because they don't like to dabble with insurance. So it's
Well,
kind of a
the
tough
mental health
situation.
one, there's the other problem too, where the insurances have not wanted to pay for mental health care on a parity side for years. And they've been getting in trouble for that too. I don't see it changing very much, even with the No Surprises Act, even with some of these insurances getting in trouble with their ghost networks. So I'm kind of I'm wanting to see if they will adjust, especially with now so many patients. What is it? This year there are more patients in Medicare Advantage plans than actual traditional
Oh,
Medicare.
yes.
So,
That's
I
really
mean,
changing a lot. Yeah.
yeah, so so I'm very intrigued how that's going, if that's going to move the needle in any way. You know what I mean? Like, because things are always going to change, right? So it's just trying to be ahead of that curve so that way you're not swallowed up by the guardrail, you know?
Well, traditional nutritional Medicare, as you know, it is probably like you're right. The numbers are going down, right, with traditional
Yeah.
Medicare, with the managed care. But what I did find though, and you're gonna find this unbelievable, but there's a rural healthcare facility that I was working with about a couple of years ago. So the Medicaid managed care contracts really benefit them quite a bit. So where normally they would get like maybe $20 to $30 a visit, they were
Yep.
getting over $120 per diem for those
Because that
visits. Yeah, it
rural
may
healthcare
it's rural healthcare.
designation, the
Yes.
FQHC
So yeah,
designation, the rural health designation, those things are worth their weight in gold.
Huh.
yes, and
Didn't
depending on
know
how
that.
you manage those contracts, you can get paid really, really well with those,
Yeah.
right? So that's where when you're looking at those Medicaid managed cares that we don't really like that much. But when you're talking about those type of facilities, then we're going, oh well, those contracts is what we want. We want all of
Yeah.
those because they're going to pay you really well.
Yeah, no, and
So it just
I've seen
depends,
some
right?
of those facilities where we say facility and people think
Mhm.
hospital. And really what it is maybe a 3,000 square foot location and they
Right,
telemedicine in the specialties. And
right.
the specialists are just contracted on a per diem, on a part-time basis, and they say, all right, you want GI, come in every Tuesday. Rheumatology every Thursday, and they just spread it out like that. But because of the way that they have those rural healthcare contracts, it actually makes it worthwhile then, and then you can see a normal amount of patients instead of 45 patients a day, you're looking at maybe 22, you know?
Right,
So
because you're seeing, who's seeing them? The examiners, the
mhm,
ARNPs are
mhm.
mainly seeing those patients.
Yeah, you have the
So
specialists just there
that's
for
how they can
consults and
afford that.
and up the billing. Yeah, no,
Right.
it's definitely very interesting. But we're reaching that time. So does anybody have any questions? I told you, Gianni, it goes stupid fast.
How long have
I
we
was gonna
been on?
Believe it or not, it's almost
about
quarter
40
after two.
minutes. About 40 minutes. Little
I
over that.
told you.
Wow.
I
We
have
Okay.
keep
I
it.
have one more question for Gianni. I remember we spoke
Yeah.
before conducting this topic, some success stories. What was your most recent one? working with a practice and doing the credentialing.
Okay, so like I inherited a really huge practice that is physical therapy. And so when I inherited this practice, I found that the people that were working credentialing for them before had dropped the ball on 350 applications. So in 5 months, we cleaned them all up. And, all
Wow.
those became enrolled. And yes, and they're all like, I mean, some of them, as we know, we still have some other that have $120 days to wait. But yeah, they dropped that ball on 350 because they were a huge practice dealing with credentialing, and they didn't really have the manpower, or some of them didn't even have the knowledge to
Yeah, I
know what to
mean,
do with certain payers.
yeah, because this is a very niche. It's a niche of a niche in the admin side of healthcare. So I mean, you got to have a little bit of billing and a little bit of admin just to even understand how the taxonomies match up with your contracts, which then it messes with your credentialing and the types of providers. So I mean, oh
Yeah.
God, some of the
And
error codes we
what I
would see.
enjoy about this piece though, Jose, is that I'm like a coach.
Yeah,
I'm a coach because, if a provider comes to me, like I had a new client that came to me, and guess what he wanted to be? He wanted to be enrolled in workers' comp. Why? I mean, like he really didn't, he was starting his own physical therapy clinic. He thought workers' comp was the thing for him. And workers' comp is a totally different animal that, you don't really credential for. You need to have to
yeah,
network with
yeah.
people. So I feel like I had to coach him. And then the love autism lady, with autism, you end up coaching them. And, don't come and pay me, like for all these contracts when it's really not beneficial.
No, absolutely, absolutely. So yeah, I mean, that's the way I would kind of, yeah, that's a great way to put that.
Yeah.
Like I mean, it is a lot of, especially on the consulting side. If you're trying to create value,
Mhm.
your billables tend to reflect that in the opposite direction, right? Because you're given a lot of time out there that you're not billing them for, but the ones that value it understand that you're basically coaching them. You're basically giving them, hey, these are the tools to be able to do this going forwards. And then you just call me and pay me for the complex stuff that are just weird. Like why did this fall through the cracks? Oh, because so and so at the insurance company, or the weird stuff that requires, all right, let me get a professional in here to really dig into this while I focus on the easier stuff that just pushes the day-to-day ball.
Yeah.
Cool.
Keeping
Cool,
track
cool,
of those
cool, cool.
reevaluations as well, the every 5 year.
Right.
Right.
Shit,
Yeah. And
That's
just
easy
talking
to
to these
forget.
payers, they take like, you can be on the phone for a good hour,
Easily
talking to
before you get somebody.
before you get somebody, and then they still won't give you the right information. So you have to call again. So yeah, so
Yeah.
I mean, I think that's the thing is like, I would love business, but I don't want to take advantage of people either. So if like this guy, who was thinking about these I mean, we worked with workers' comp contracts for him,
Mhm.
but at the end of the day, when he started his practice, he was like, well, this is not working. And I said, well, told you it wasn't going to work.
Yeah. I mean,
Now let's go back to the other stuff.
For workers' comp, I feel like the best outlet for him would be lawyers.
Lawyers, connecting with the on-call services that work
Yep.
with, physical therapists. Those are the kind of people that, and networking, not
Yep.
contracting, right? Not contracting.
Yeah.
Yeah.
Yeah. I
But
actually, if you talk to him, because he's a PT, I actually know of a PT that what he did
Mhm.
was that he got with the HR department of a large paper mill
Mm.
and he became their on-site PT.
Wow. That's great.
For prevention and for quick access to the physical therapy before they even left the site, even thought about talking to a lawyer, and it reduced their claims and sped up the recovery of their employees. So it just paid for itself within the first year.
And you got paid directly from
He got paid directly from the company.
yeah, see?
You know what I mean? Like, and
Yeah.
of course, the ones that would go through workers' comp, it'd be like, okay, cool, you're going through workers' comp, but you could go to the PT that's on site,
Mm-hmm. Yeah. So,
So
yeah. So you're looking at, what is it that you're trying to accomplish? what is it going to be beneficial to your practice?
Yep.
Yeah, and then
Yep.
like you said, if you're in a like a niche type of practice, does it really help you with enrolling in all these insurance payers? Or do you want to just do cash? So those are the kind of things that you have to look at. And you know me, I've been around for a long time, and I worked
Yeah.
in practices and I've managed them. So I have a lot of experience in those. So I feel like I can offer some coaching type of scenarios for people before they look into, is this a good insurance plan like Cigna? Do you really want to go through Cigna and get paid, little price, or do you
Yep.
want to just go for something else like maybe TRICARE, and let's look at their contracts, do they have a good contract or not? So
Absolutely.
TRICARE right now, all their contracts are out of network, but they pay really well.
Yep.
But
Yep. So I would even tell everybody, if you don't know how much it costs you to provide a service, you cannot figure out whether the contract is good or not.
mhm, that's
You
true.
gotta know what your numbers are. You gotta know how much it costs you to see a patient
Mhm.
for every single service that you do. Because if you don't, you're gonna sign up for contracts and you don't know that you're losing your shirt.
Right. That's
And I
right.
see that way too often too.
Right. And if you want to look at some numbers, you can probably look online, and see if you can find like, how many patients may be enrolled in or a certain type of, payer, like for
Yeah.
Cigna. Maybe I can find some numbers online in your area and see if it's
Yeah.
even worth it.
Especially with all the ones that are publicly owned, because they have to report all that information to their shareholders. So you can usually find that in the quarterly earnings or the annual earnings, and then their projections as well. You can find that. So again, these are things that a lot of people in healthcare never would even think of looking at. Quarterly projections and earnings from a company, like where would you know what I mean? So a lot of times that's where we create our values, that it's not necessarily what we know, but we know where to look for the information to get it quickly. Some of that stuff is rather esoteric, so you really have to know where to look for it, and in regards to anything federal, because they posted, but good luck finding it.
Right.
They don't have a database for all of
Nope.
the final rules,
Yeah.
so um
But
so
Jose,
yeah, so
I know like we are so involved in this consulting business and trying and getting information. Most practices are busy doing their daily work, dealing
yep,
with the physicians and
yep.
the employees and stuff. They don't have time for stuff like that. So I
Oh,
think
no,
it's
no,
really nice
no.
that you guys offer this podcast and inform people and help them guide them in certain areas
Well,
where.
Jose, weren't you reviewing a subpoena earlier too?
I was actually, yes, we were discussing a subpoena for a client. So yeah,
Yeah,
it's funny how all that stuff it's daily. It's absolutely daily.
I
I
know.
mean, I was just reviewing also um policy and procedure regarding firing somebody for, let's just put it, moral turpitude, but they haven't been convicted yet.
Oh,
So so
sounds like fun.
yeah, it's definitely one that I'm like, all right, well, we need to make sure that everybody's trained on this, and then are we suspending them without pay, are we firing this person outright, like how do we get out of this as clean as possible? So
I
it's
know,
fun stuff. It's absolutely fun stuff.
I know. But
So
this
to
is
be
great.
clear, that wasn't in my practice. I mean, the more
I was
to
waiting
be
on you to
perfectly
say
clear. um
that.
but yeah, so yeah, we appreciate having you, Gianni. Ray, what do we have on deck next week? Because I'm been out of sorts all month.
Yeah, so next week's session, we're going to be talking with one of our longstanding EPICompliance customers,
That's right.
multi-state, multi-location. We're going to be interviewing one of their compliance administrators and sort of
Right.
interview her on the success that they've had implementing a compliance program across the board. And I know you know this, Jose, when you're dealing with multi-state, multi-location organizations, it's tough, to sort of maintain all the compliance and everybody be on the same page. So
You know what's funny? The hardest thing is every single location becomes its own personality.
Exactly.
Right? Have you noticed that, Gianni? Like it can be one organization, but if there's 5 or 10 or 12 offices or even 3 offices, the office takes up a similar personality to the office manager.
Exactly.
And so you're managing multiple personalities within multiple personalities, but it's all one organization. So how do you from the top down push and you know, and I'm curious to see what Heather's response is going to be, because one thing for me is always I got to push from the top down, but I got to incentivize and empower them to push from the bottom up as well.
Right. And that's essentially something that they've implemented is there's some incentivization for these office managers to meet these compliance goals. So
Right.
I'm interested to get her take, and
Yeah, it's awesome.
should be a pretty good one. But
That'll be
Gianni,
great. That'll be great.
we appreciate you, and you know, this won't be the last one. I'm sure we'll have to continue down the rabbit hole on the
Yes.
convention.
Definitely.
Thank you so
But,
much, guys. We do
I
appreciate
did
it.
share a slide with Gianni's information for the audience if they need to get a hold of you. You can take a screenshot of this. Also, this video is going to go up on our YouTube channel as well. Gianni will make sure that your contact information it gets put in that as well.
Thank you. You guys
And
have
as
a
always,
great
if anybody's
day.
got any, and as always, anybody's got any questions or concerns, you guys can always reach out to Ray or myself, and we'd be more than happy to answer the question or even take a deeper dive into what your topic it would be that you would like us to cover. So,
Absolutely.
yeah, perfect. Thanks, guys.
Thank you.
Yeah,
Have a good
thanks,
day.
Gianni. Thanks,
Thank
Jose.
you.
You guys take care.
You
Thanks
too.
everyone for
Bye.
attending.
Bye.